Thank you, Klaus, and thank you everyone for being here. So this is a sort of wrap-up lecture after so many discussions about rotator cuff repair. The question they asked me to answer is, do we really need implants for a successful arthroscopic rotator cuff repair? Very quickly, of course, there is a long history, and Pietro Randelli did a wonderful overview when he presented his keynote lecture. But the story of repairing the cuff is one of the many challenges that are in the hands of the shoulder or the orthopedic surgeon in general, in a general sense. Starting with all these big surgeons, Codman, McLaughlin, they described many different possible techniques. Then arthroscopy came. I put some historical picture of my repair. Probably they're close to 30 years old. Pictures, you see the Caspari punch and so on. All the tools were evolving, and the anchors and the system. So the rotator cuff repair approach evolved from the single medial row configuration, then mimicking the transosseous effect with a double row, suture bridge, and so on and so on and so on, trying to reach the best result. And again, this was very clearly described. But generally speaking about the outcome of rotator cuff, we need to have a benchmark, like in business. What is the gold standard to judge what we are doing? And open rotator cuff repair remains the gold standard for comparison of different surgical techniques. This statement is not of many hundreds years ago, but quite recent, and still the gold standard, the benchmark, is coming to this open transosseous rotator cuff repair. And this is the image coming from a Pietro paper that is describing the evolution. We started with the open repair, then we moved to the mini open technique, and it is when I approached it, then arthroscopic with the suture anchor, and something is coming back in this pendulum swinging that is arthroscopic transosseous repair. And it is not born the anchorless repair that is a transosseous arthroscopic. It is not born yesterday. It is now probably more than 20 years old. You see Dr. Fliga with the giant needle, and of course Sumant Krishnan with the arthro tunneler. That was the one inspiring me very much. Then other authors that were using the ACL guide, or Kurt Passer, Herbert Resch with this big needle that used to do so, and then the tailor stitch came, and other possible techniques were described. Then anchorless repair of the cuff. Again, the question is how they are performing, and this is what I try to do on my entire professional life. There's to turn my head behind and check if what I did was really working nicely or not, scratching my bald head. And I did a few papers with my co-workers and cooperated in my team. This is the first one, and it is dated 2012, so it is 10 years ago. Then at that time we were using the transosseous arthro tunneler system with the X-box configuration as described by Sumant Krishnan. And this is a little group, of course. It was the really beginning. We had a good healing, 28 out of 32, with a good biomechanical testing, and we were happy with the early results of this technique. Later on, 4 years later, we reported the outcome of this over 100 consecutive patients. We do a 1-year follow-up and satisfactory subjective clinical outcome, no complication, and this was strengthening our confidence in the no anchor rotator cuff repair. But this is the study that is much more important in our experience. It is a level 2 evidence study with an MRI evaluation of our repair. 24 months was the minimum follow-up, so quite significant. MRI and comparing, so level 2. And this is the group of the study. Transosseous, arthroscopic transosseous is the left column. And suture anchors, they were vented, the vented anchors, so we were expecting to have blood coming up and giving the same biological benefit. The group is similar in terms of number, 50 versus 42, and you see here the results. The retear, we followed the Sugaya classification. The retear rate was very similar, 18% in the transosseous, 19% in the other. Grade 1 of this healing of Sugaya classification, 38 to 23, grade 2, 40 versus 31, Grade 3, it is quite different then, because we have 4% only in the transosseous and 26 in the suture anchors, the vented suture anchors. Overall, the outcome was very similar, 82 versus 80, so similar. But now I like to focus my attention this grade 3, because nothing was different in the difference in the UCLA constant and ASIS score. Overall healing, again, good, no significant difference, but 26% of type 3 healing, according to Sugaya, is telling me something, because it is probably a poor healing that we are obtaining, and many other authors were talking about rupturing continuity or healing with scar tissue, and this is the type 3. So maybe that more bleeders and that kind of suturing is leading to a little better biological local response. So this was something about the technique and the results that are basically the same. But another important aspect that was analyzed earlier this morning is the cost effectiveness. So this is a study not from me, but very, very interesting. Look at the numbers, because we start looking at the cost of the things we are doing more and more carefully. You see in the left column, we have the size there, small, medium, large, massive, total. Then we have, for each case, the implant cost, the total cost, and the case length. And you have transosseous equivalent, and then in the third column in the cost, you have the difference between transosseous and transosseous equivalent intended with the double row repair and so on. And you clearly see that if you do transosseous with a small tear, you can save in the US market almost $1,000, and the case length doesn't make any difference. It is the same time-consuming operation. The larger is the tear and the higher number of anchors you are using, the gap of the cost is increasing, reaching in the final group over $1,000 for each case. And again, the time consuming, it is much more, not much more, a little bit more time consuming if you do a transosseous repair. And overall, small, medium, large, and massive, you have a difference of about $1,000 from transosseous and transosseous equivalent, and you can even save a few minutes. Let's go to the same consideration. This graph here is indicating in the blue is the transosseous, red is transosseous equivalent, all tear size, it is the difference in terms of cost, and the larger is the tear, the more money you can eventually save. And is this just money and the clinical effect is different? Well, same study is demonstrating that if you look at the bottom right graphs, you see that transosseous, the graph is telling you the baseline, 3 months, 6 months, and more than 12 months of observation. You see that clinically speaking, they are very, very similar with the minimal difference in favor of the transosseous. Furthermore, this is a very creative technique. You can play with the system, and there are many systems out there. And I always mention a statement that the fantasy is the limit. One point that we outlined earlier this morning is that the bone quality in the greater tuberosity in the humerus is important, and sometimes you may use some augmentation for the bone to protect it, otherwise all the system will fail. So this is the real weak point of the idea. Surgeon fantasy is the only limit. You can play with the suture in as many ways as you want, and it is very creative. Here are 3 possible techniques. They are quick, 40 seconds, classic, that I'm coming from the lateral, as I showed earlier this morning. The transtendon, you can repair the pasta lesion, my right shoulder, or the reverse entry that likes very much Jean Cani is doing this a lot of times. It's easy, you come from top and you get out from in the lateral part, so you're very precise entering where you want to have your suture pulling down the tendon. So again, you can play with this. It is like a toy in your hand. Once you are becoming confident, you don't even need that much system to aim your target or so. Of course, there is a learning curve like every single procedure, but everybody can learn it and achieve good results. So as a conclusion to the question, do we really need anchors? What I should say that anchor or anchorless system, they are equivalent in terms of repair integrity. They have failure in both sides, but the problem is probably not the technique, and we were through it very clearly during the entire session. The biomechanical strength is good. It is anyways a reliable, reproducible technique with the anchors or without the anchors. You can play with many sutures, and it is true for both. Anatomical repair and avoiding over-tensioning is probably better in transosseous because you do not over-tension in the medial row. And what I showed earlier in the clinical case this morning, it is an easier reoperation if you have a re-tear after this technique. So this is the picture that I put in my first article 10 years ago. It is a pendulum swinging probably in the history of rotator cuff repair. We started when I was a student with open transosseous, then we moved to mini-open transosseous, then mini-open with anchors, then arthroscopic with anchors, then arthroscopic with single row, double row, transosseous equivalent, different technique, and probably somehow we are going back to arthroscopic transosseous. It is not a competition, it is just an evolution. Thank you very much for listening. Thank you.